Okay, you may have noticed this is a pretty brief lecture talking about urinary pathology, because I whittled it down to just what are the bare essentials, what are the things that we actually can see radiographically, what are the things that we opt to punt. And so I know that y'all are at a point in your clinical, now not just your clinical studies, but some of us even in our clinical work where we start seeing orders that come across and it's like, why are they ordering this? You know, that type of thing. The urinary system is probably top of that list, in my opinion, because particularly with things like kidney stones, post-transplant questions, a lot of that is going to be best handled by sonography because zero ionizing radiation, we can get really, really great pictures, and frankly, if anything's seen on CT or on X-ray, likelihood they're going to do a comparative ultrasound anyway. So why aren't we doing the ultrasound first? Is kind of one of the big questions that happens a lot in CT with the urinary system, and I think it's there as well in X-ray. So I want us to be familiar with some of this pathology as a means to know whether we're actually supposed to be taking the front line on this, or whether honestly there's some miscommunication between our department and the emergency room or the floor or whatever, because I'm sure y'all can already think of lots of examples of times where the communication broke down, they're ordering tests left and right on this patient, and I'm not really quite sure why they're ordering this one, right? So my expectation for y'all as X-ray techs is that you're able to work with your physician, with your radiologist, or whoever's reading the exams to identify those things that may have been misordered. That's one part of it. The other part is that we do need to have that firm foundation in urinary anatomy, right? It is one of the few physiological sections of the body that we need to have some physiological knowledge as X-ray techs. We need to know this kind of detailed anatomy of something other than the skeletal system. So the learning objectives I've identified is we'll talk again about anatomy and physiology of the urinary system, so you're probably starting to notice a trend in the way that these lectures work. We'll talk about tube/contrast considerations, and y'all have had quite a bit on contrast, so I won't spend too much time there, but I do want to make sure that we're familiar with how the anatomy of the kidneys works in the presence of contrast. Then we'll talk about renal agenesis, fusion anomalies, positional anomalies, calcifications, and hydronephrosis. The thing that you'll notice that's not on this list is a discussion of cancer. Renal cancers are pretty darn rare, and we are not necessarily frontline for diagnosis of renal cancer. CT maybe. MRI is a more likely candidate. So, and it's also a very rare form of cancer. So I wanted to focus more just on these things that we see more every day and that are definitely more part of our day-to-day work. And then we'll talk about both additive and subtractive radiographic techniques. So looking on the textbook on page 212 and 213, it is helpful to know that primarily the anatomy that we're looking at is retroperitoneal. It's there behind the peritoneum. 2 kidneys, 2 ureters, the urinary bladder, and the urethra. The urinary bladder is going to be below the peritoneum, so not necessarily retroperitoneal, but below it. And the functions of it are to form urine and excrete waste from the bloodstream. And if that is not happening, all sorts of other stuff can happen as well. So there can be neurological changes, there can be change in blood pressure. It's significant that this filtration process for the body needs to be occurring. So it is integral to the body's function. To understand that functional aspect of the kidneys, we kind of have to zoom in. So this is what I'm talking about, being familiar with this kind of zoomed in functional anatomy here of each one of these little funny bean-shaped organs, even though they don't show it very well on a KUB, right? And you may struggle to identify them on those images. That's okay. You need to be familiar with this anatomy here, each part of this slide here, as well as I think it's helpful on page 213, this little illustration here. I couldn't find a good version of this to put into the PowerPoints, but this is an important illustration. Expect to see this illustration, if not on the quiz, at least on the exam, because I want us to be able to identify things like Bowman's capsule and all these little tubules, loop of Henle, stuff like that. Each one of those is important and significant to the way that the nephrons work. So to start at this zoomed in level, kind of tracking out on our textbook, the way that this little system works here is you have arterial blood, right, that's pumped through this Bowman's capsule, which inside of it has this glomeruli, little tiny twisty thing, right? This is then allows for filtration from the blood of any impurities, right? So it goes into these little tiny twists and tubes. That filters out bad stuff, filters out the impurities. Those wind up in a proximal convoluted tubule, and then the loop of Henle, and then it drains into the renal pelvis. Okay, so that is that functional unit called the nephron. To zoom out just a little bit more and now look holistically, when we have a whole bunch of nephrons, what we're talking about are these major calyces, right? That those are these kind of fan-shaped pieces of anatomy that have all these nephrons kind of fanned through that anatomy. And so you can see those, let me see here. So renal cortex is where the nephrons actually are. Calyces is where they're at, the major calyces. Those drain into minor calyces, and they kind of look like pomegranate seeds to me on this illustration in the textbook. Those then drain into the renal pelvis, right? And ultimately the renal pelvis then drains into the ureter. So that functional thing, that I know it seems kind of weird, like I think about my boys right now who are really into, we were showing off, we're thinking about renting out the guest house, and we're showing it off to a couple yesterday, and my son Dylan runs out from behind this fig tree and said, "I peed behind that tree over there." And it's like, great, Dylan. Thank you. I mean, he's 4. But, so this is not just that we need to be interested in stuff the way that my 4-year-old son is, but we need to be familiar with the functional units of this because it's filtering out impurities. One thing that I want to point out here is with this bean-shaped organ, there's some stuff that almost gets used interchangeably sometimes. So be aware that the renal pelvis is this large kind of, I don't know how to describe its appearance here. This large kind of open space right here. That is the renal pelvis where all of the minor calyces drain into, right? But then this little gap here is called the hilum. And you'll notice it includes things like the renal pelvis, the ureter, the blood vessels running to and from the kidneys, right? So be familiar with both renal pelvis and hilum. For the most part, when we're accessing this system, we're accessing it in a retrograde fashion. So we're watching as a urologist runs a cystoscope, right, up into the ureters and then into the renal pelvis, right? So since they are working through the ureter, they're winding up in the renal pelvis, but they're still in the area of the hilum. Kind of weird, but I want us to be familiar with that. If, for example, though, we're accessing it just through the skin, they may go directly into the kidney, and they're kind of working in the area. They're accessing it through the hilum, and then into the renal pelvis. So, in terms of where these functional units, though, are situated, again, retroperitoneal about the level of T12, so just below maybe the xiphoid process, you're probably in the area of the kidneys. So as I've been instructing the junior students on setting up for KUBs, asking the patient to indicate where the xiphoid process is helpful, because I have a general idea now, okay, I'm about in the area where the kidneys need to be in terms of my light field or whatever for x-ray. Within that hilum, if I haven't mentioned it already, and I just realized I've lost my radiation badge. It was that kind of week last week, I guess. We also have renal artery, vein, all sorts of lymphatics, and nerve plexuses, right? again, the nephron is that functional unit. I've discussed it in some detail, and I think that's all we really need to know in terms of both anatomy and physiology here. All right, tubes and contrast stuff. Turning the page here. Let me see, tube page. Oh, and I skipped over the bladder. I'm sorry, the bladder gets short shrift sometimes. So the bladder is where these ureters are draining down into. It is situated just behind the pubic symphysis, or that's where it should be. Occasionally we have things like bladder prolapse where it slips a little bit lower, but it can hold about half a liter, right, before it starts to fill full, right? So sometimes I've seen registry type questions that ask you, how much urine does a bladder hold, and they've got some really specific numbers here, like it can store up to 600 milliliters. I don't give a crap about any of that. Like half a liter is helpful to know. Like that's actually something that I can imagine on a grocery store shelf, right? About half a liter is what a bladder holds for an adult. Let me look at, where's the stuff on tubes? Okay, skipping forward to page 226 then. Let's talk about these urinary tubes and things. The first that we should think about is the nephrostomy tube. That's what I have here on the CT image. I used to assist in placement of these things all the time, either with CT or with C-arms or whatever. It connects to the renal pelvis to the outside of the body. So we go in through the rear of the person's body, basically stab a long pokey thing through the skin, access the renal bladder then with this little stent, right? It kind of coils up, and that coiling is what keeps it anchored there in the renal pelvis. Because if you can go back to that image of the kidney anatomy, the pelvis is pretty large, and the ureter is pretty small, so it's like a funnel shape. So if we can kind of coil it up in the pelvis, it's not going to slip out. That is, again, a nephrostomy tube. Versus a stent. So these have got to be placed surgically via a cystoscope. So cystoscope is something that's going to be run up the urethra, right? So the surgical access point is the urethra, right? Through the bladder. In the bladder, they send the scope up to one of the ureters, and then up through that ureter, right? So we can see all of that on this video screen. It looks like you're playing like Doom or some first-person shooter or something. Like you're kind of traveling through these weird, creepy tunnels, right? And there's lights and there's laser guns and all sorts of stuff that they can access through that scope, right? I think in another life, maybe someday I'll be working in that field. I don't know. It fascinates me. I love that they get laser guns to blow up like kidney stones and stuff. But what they're doing as they place that cystoscope oftentimes is creating a stent. And that stent's going to be run up the ureter, again, to the renal pelvis. It will coil up in the renal pelvis and stay anchored there. And when you see it on x-ray, which you've probably seen on x-ray, it's just going to look like a long line of plastic. And it looks like the thing's blocking it off, but in actual it's doing the exact opposite. It's a long drinking straw that's allowing it's keeping patency or allowing the ureter to remain open, right? So if there's disease in the ureter or whatever, the stent's going to keep that diseased ureter open. That's really important to the health of the kidney. Because again, the kidney is functioning to filter out blood. And if something happens with the drainage part, all of that backs up now. All of those toxins are backing up into the kidney. They're supposed to drain out of the kidney, and they're backing up into the kidney. That's a problem. So one of the things that we might use, and last thing, I know it's not on the slide, but a Foley catheter. You probably have all seen tons of Foley catheters, right? The Foley catheter, again, is placed under sterile procedure, minimal anesthesia, up the urethra, right? And there's a balloon that then anchors it in the bladder, the urinary bladder, right? And so be careful with those as you're working with patients. They're commonly associated with things like urinary tract infections and things like that. So maintaining some degree of, sterility or trying to protect that as you're working with patients is important. In terms of the contrast stuff that we use to look at this collecting system, CT, of course, IVU or an IVP, those terms can be used interchangeably, right? So that means intravenous urogram or intravenous pyelogram, they're basically the same thing, right? Urogram just meaning urinary system, pyelogram meaning like kidneys. Retrograde pyelogram, and then the renal angiography. So each one of these studies, though, is looking at different things. Okay, so I want to kind of break that down for you a little bit. With CT, we can look at the kidneys without contrast or with contrast. Without contrast is super helpful if we're just trying to see kidney stones. Any kind of calculi, no contrast. We do not need contrast. We do need to question why we're not going to ultrasound first, but we do not need contrast. In fact, the contrast would get in the way of what we're trying to see. If it's anything else going on with the kidneys, hydronephrosis, or we suspect that there's some kind of ectopic kidney function or cancer or what have you, we do need contrast. So it's very common for certain renal protocols for us to do maybe without and with, those types of things, depending on what we're looking for. So that's the CT world. In the world of fluoroscopy, right, we might do these IVUs or IVP. And the important thing here is the IV. This is intravenous. So we are injecting contrast into a person's brachiocephalic vein or wherever, right? And that contrast is filtering through the blood system and winding up where? At the kidneys, where blood is filtered out. And since the iodine is completely useless to the body, the kidneys filter it out, and now we can get a functional picture of the kidneys filtering out contrast, right? So access through the intravenously, and a functional image of the kidneys filtering out contrast. So I always kind of laugh a little bit to myself when folks from Nuke Med talk about how they're the only people who do functional images. That's not true. Otherwise, what was I getting paid for when I did all these contrast studies? Right. Those were functional images. Okay. Versus retrograde pyelogram. The patient doesn't even need an IV for this. I'm accessing the kidneys retrograde. We're going up through the urethra to the bladder, and we're either creating sufficient pressure in the bladder, if you can imagine that, with like a half a liter of stuff, and we're forcing it back up the ureters due to the pressure. We're causing backflow into the ureters, or we're accessing through the bladder up into the ureter and then causing backflow in that direction. That's what retrograde means, going against the grade. The grade is downhill and all this stuff filters out of the kidneys. We're going against that, and we're getting the contrast up into the renal pelvis in that retrograde fashion. That's retrograde pyelogram. Finally, renal angiography. Now, this can be done in a number of different ways. We can do this with CT, we can do this with fluoro, but the point now is to not even look at any of the nephrons or anything. We're just looking at the arteries. You know that you've got, especially on CT, you've got a good CT angiogram of the kidneys if they're glowing like a light bulb. They literally look like they're glowing like a light bulb. You don't see any contrast in the renal pelvis. You don't see any contrast in the ureters. You just see contrast in all those glomerular capsules, all those Bowman capsules that are out there in the renal cortex. Sorry, name slipped my mind for a second. So you just see contrast in the cortex. That is any kind of angiography, looking at the arteries feeding into the kidneys and those functional units there. Maybe a couple of quiz questions as well, asking you about contrast and contrast reactions, right? Mild, moderate, severe, all those types of things. All of that feeds into this, right? So anytime we're giving a patient contrast, we need to be aware of things like, did they sneeze? Do they say that they can't speak? Or is their throat closing off? Those types of things, and the necessary response. Has anyone been there for a contrast reaction yet? Nope. Oh, looks so excited about that. I guess it'll happen.
I had a lady get hives after her
Yeah.
treatment.
That's definitely, it needs to be documented. Okay, so we have seen some of it. It's not normally as severe as I have to make it sound here in the classroom. I'm kind of prepping you for the worst possible stuff, but most of it's, like he said, hives and things like that. All right. Renal agenesis. So we've already seen this word agenesis before. It just means something didn't get formed correctly, right? So this is an absence of one kidney, right? There will always be enlargement of the other, right? We call this compensatory hypertrophy. So because there's only one kidney doing the work of two, you're going to have additional size to that one kidney, right? It's pretty rare, one in about 100,000 individuals. There is a thing called Potter syndrome. I don't have any cases of it that I could find images of, but this would be incompatible with life. If an individual is born without kidneys, there will be constant toxins circulating in their bloodstream, which is going to damage the heart, damage the brain, all sorts of things like that. Then there's supernumerary kidneys, and this is the presence of a third kidney. I always think about this guy that I ran cross country with that for some reason had a third nipple. But it's supernumerary kidneys. Yeah, he got teased mercilessly, I'm sorry. This is basically the third nipple of the kidney world. Again, pretty rare, but it's often symptomatic due to infection. It's not going to be, it's smaller, and it's not as functional as the normally sized kidneys, and so it's going to be prone to infection. As I'm following along in the book, this is page 229. Hypoplasia, which we've already kind of explored to some degree, is just it's less developed. And with the kidney, this is almost always associated with opposite side or contralateral hyperplasia, right? And then associated hypertension. So anytime we start messing around with the kidneys, you are also messing around with the heart and messing around with the brain. So I can think of examples from my own life, a family member that I had that had increasing kidney dysfunction as they got older, and that started manifesting as dementia and high blood pressure, right? The root of the problem was kidneys, though. So something to be mindful of as you're working with patients who are on dialysis or who are having kidney problems. Bear that in mind, that you would expect to see increased high blood pressure, things like that. So this is, again, one of the reasons why prior to administering contrast, given the population that we're working with, get the person's blood pressure, right? Because they are that much more prone to hypertension. So if, I don't know. Versus hyperplasia, which is overdeveloped. And this is going to be often associated with an opposite side, hypoplasia. So there's basically two different ways we can look at the situation. But we should be familiar with both of those terms. One thing that the textbook points out in terms of renal agenesis, going back to that prior slide, is this can also be called aplasia. And that's on page 229. Okay. Other congenital things that we are concerned with the kidneys is what we call fusion anomalies. Horseshoe kidney, you've probably examined someone by now who has it, or you've heard about it in your department. It's the most common fusion anomaly. It's a very small portion of the population, 0.25%, right? So less than 1%. And it typically happens in men more often than women. You can see it, let me see. This textbook image here on page 230 was not really clear to me. I couldn't see where it was crossing the midline, so I went ahead and grabbed this. I think this is an IVU or IVP here, where we've injected contrast, and we can see it in the renal pelvis, and we can see how that renal pelvis is kind of crossing the midline, crossing the lumbar spine. So the kidney is basically this U-shaped, kind of partially connecting renal pelvis. Another fusional anomaly is what we're going to call crossed ectopy. Now, if we just are talking about an ectopic kidney, that is a positional problem, right? The kidney's not in the right place. But what we're saying, this is crossed ectopy, so they're partially connected, and one of them completely crossed the midline in the midst of being connected. So horseshoe shape, they're connected across the midline. With crossed ectopy, it's crossed the midline, right? So we can see on this other image here, we have the kidneys are both on the patient's right side, and it looks like there's possibly even a single ureter draining into the urinary bladder. So we can have it where there's two ureters, like here on page 231, from each of the crossed kidneys, or we could have a single ureter. There's different, anytime we have an anomaly like this, there's going to be different types of anomaly, right? If either one of these are causing discomfort or problems with the function of the kidney, it may need to be treated surgically or in some other way. Okay, these positional anomalies of the kidneys are also significant. This is page 231. The first is malrotation, which I think we've already heard that term in this class, but if the kidney is not sitting in the appropriate plane, we would expect to see this malrotation problem. So the kidneys kind of sit back like this. The way that I was taught to imagine kidney anatomy is to hold your hands up like this, right? And now you have a good idea of how the kidneys are situated inside of your abdomen. So the north pole, you'll notice, is a little bit more posterior than the south pole, right? It's a little bit more anterior. If they're rotated like this, that's a big problem. Because if you rotate like this, you've just kinked off the ureter, right? And again, if there's anything causing blockage or backflow of the urine back into the collecting system, that's a problem. So that is what we have in this illustration here, is a very pathological malrotation of the kidney where it's actually twisted back on itself and wrapped up in the ureter. Ectopic is just out of normal position. So this is fairly common to be found in urologic examination, oftentimes asymptomatic. So the normal location of the kidneys is that the right is going to sit slightly lower than the left because the liver kind of pushes down on the right. So you'll normally see the north pole of the liver first on a CT exam or whatever. And then, but if the person's had a kidney transplant, or if the kidneys just kind of sit in a funny place, we call that an ectopic kidney. Typically asymptomatic. If it is causing obstruction, then it might need to be treated surgically. And then nephroptosis is a kidney prolapse or pelvic kidney. So again, if it's slipped down into the level of the pelvis for whatever reason, we will call that a pelvic kidney or nephroptosis. Okay, I did want to at least throw one ultrasound image in here and expect to see some ultrasound images as we're looking at this stuff, but probably the easiest one for me to look at, because this is like one of the few ultrasound studies I can look at and say, yeah, there's something going on there. Everything else I see on ultrasound is like, what, there's like a storm this afternoon coming in over the interstate? Like, I don't know what I'm looking at here. But this is clearly showing a kidney stone, right? And the nice thing about it is you can see kind of the shadow being cast by the stone, right? This kind of shadow here. And what my understanding is, the way that these pictures function is you have the transducer right here that's producing the sound waves, right? And what it's picking up is the echoes back, right? So it can tell that this is forming an echo signal. This is definitely forming a really strong echo signal. It's echoing back towards the transducer, right? And then we start to fall off. Out here is basically the noise, right? It's just noise. I can't hear anything out here, right? So up here I definitely hear this, and this is not only so noisy that it's creating this strong signal, it's also I can't hear anything behind it. So I know that that's definitely calcium or calcified or somehow hard, right? So this is showing me a lot. It's showing me, number one, why ultrasound can't do very much with skeletal anatomy, right? But it's really good at the soft tissue stuff, particularly if it's fairly superficial to the surface of the body. So calcifications, ultrasound is a great first line of defense. Make sure I'm keeping my thing. So urinary calculi, second only to gallbladder calculi, so they're up there. And I can tell you, if you ever worked graves at an ER, around 2 o'clock in the morning, that's when all the kidney stone people stumble in, right? A lot of them wind up in the calyces or the renal pelvis, and then they cause a lot of pain, right? The way it's been explained to me, our textbook kind of alludes to this, is that the calcium, as it calcifies, as it forms this crystal or this stone, it has these little tiny hooks that it's forming as well. Its surface is just kind of covered with hooks. And so it's able to basically put these little fish hooks in the tissue of the renal pelvis or whatever, and that causes intense pain. Staghorn calculus is actually going to start to fill the renal pelvis itself, and maybe that is the best way to think about what the shape of the renal pelvis looks like. Is it looks like a moose horn or a deer's horn, right? So it starts to form a calculus throughout the entire renal pelvis as a staghorn calculus, and those are the really fun ones to get the laser gun on, right? I can tell you that's very satisfying to shoot with a laser gun in terms of cystoscopy. Do y'all know what I'm talking about? These laparoscopic type stuff that they do to bust up stones is what I'm talking about. They use little laser guns and stuff if they go up with a cystoscope. To diagnose this, I wish that this was flipped, but the way the textbook presents it is CT and, oh, by the way, ultrasound. But I would say ultrasound and, oh, by the way, CT, because that really hit home for me when I had an opportunity to sit with a radiologist while they were reading CT studies, and it was remarkable to me how many CT studies they referred to ultrasound. They're like, need ultrasound follow-up, need ultrasound follow-up. So ultrasound CT worked in conjunction a lot. But the stone study, again, to emphasize, no contrast. We do not need contrast to see this. The contrast would obscure it. With sonography, we'll be able to clearly see it if it's of sufficient size. If we have an obstruction at the UV junction, right? So down in the ureters, what we get is, we call that a renal colic, right? So it's different from a kidney stone. It's now a renal colic, this obstruction. And it a lot of times causes the backflow up into the kidneys. So on a CT scan, all we might see will be hydronephrosis, right? We will just see that backflow up into the kidneys. So let me see, that's on a separate page in our textbook. On page 244, it talks about hydronephrosis, and there's images that show what hydronephrosis looks like. It's basically it means water on the kidneys, is what it literally means. And you can imagine it's not a good situation, right? To have that much pressure on the kidneys. Kidney stones are typically treated. We just kind of watch and wait, give the person pain pills, see if they can pass it. If it's too large to pass, then they may have to do something in the OR to either bust it up with sound waves or with lasers or something like that. So here's our discussion of hydronephrosis. I have a CT image indicating the hydronephrosis. This is not something that would be apparent on X-ray. We cannot see this on X-ray. So The causes linked to this are frequently kidney stone or any kind of blockage of the ureters. The blockage can just result from pathological conditions of the ureter itself. It might not necessarily be related to a kidney stone, so it can develop on its own. But again, the kidney stone is probably the most common cause of hydronephrosis. If this is a persistent condition, this can result in loss of the kidney. Right? You can have kidney problems that wind up just repeating and repeating and repeating, as some of us know full well, and the kidney starts to atrophy. Diagnosis, typically sonography or spiral CT, right? It's going to be our friends for best seeing this. And in fact, this entire chapter, with the exception of the stuff on cancer, is pretty much more of a conversation about CT and ultrasound than it is necessarily about X-ray. So in terms of the X-ray stuff that we need to know, the technique-wise type stuff, we have kind of a mixed bag here. Polycystic kidney disease, which I kind of skipped over because, again, pretty rare. It's subtractive. The cysts are degenerating the kidney's function. All of the pretty much everything else is going to be additive, right? So all these pyelonephritis, the calcinosis, those types of things. So I don't plan on asking you a whole lot of additive, subtractive questions about this, but we've just kind of got accustomed to having these at the end, so I figured I'd include it. Thank you.